Revision anterior cruciate ligament reconstruction in combination with meniscal and osteochondral allograft transplantation for complex knee injury. Here are our disclosures. The patient is placed in the supine position. After induction of general anesthesia, the operative knee is prepped and draped in a standard sterile fashion and is then examined. Abnormal Lockman and pivot shift tests are appreciated, as shown here. To begin, a 1.5-inch posterior lateral incision is made proximal to the lateral upper condyle, centered over the posterior IT band. A suture is passed with a curved Kelly through the notch, and the lateral wall of the lateral condyle is decorticated for the over-the-top graft location. On the back table, an Achilles tendon allograft is prepared with a 10 by 20 mm bone block for the tibial side. Additionally, 2 draw sutures are attached in the bone block, and the tendon side is prepared with a number 2 non-absorbable suture in whip stitch fashion. Next, the tibial tunnel is created with a width of 9 mm and dilated to 10 mm in the anatomic footprint. The footprint is then prepared with the use of an arthroscopic shaver and is ready for graft passage. The graft is then passed transtibially. The graft is then cycled for an impingement-free, full range of motion 10 times for stress relaxation. The femoral fixation is performed using 2 small staples and the metaphyseal flare to fix the ACL. Tibial fixation is delayed until the remainder of the procedure is completed. We then proceed with meniscal allograft transplantation. The medial meniscal allograft is prepared on the back table. The top side of the allograft is marked as shown. An osteotome is utilized to carefully prepare the bone blocks at the end of each root. A number 5 braided suture is then used to secure the posterior and anterior roots in a modified bundle fashion. The root insertion tunnels are then created using the ACL tibial guide with direct arthroscopic confirmation of tunnel placement. Once these tunnels are created, a suture passing device is utilized to pass the previously placed posterior root sutures into its corresponding posterior tunnel. The graft is then inserted through the dilated anterior medial portal and positioned posteriorly. Of note, an arthroscopic probe can be used to help position the allograft in the correct position posteriorly while pulling tension on the sutures that were previously passed through the posterior root tunnel, as shown here. We then proceeded with provisional fixation of the meniscus allograft. The graft is secured peripherally using all-inside meniscus fixation devices. We place 5 devices on the upper surface, starting posteriorly and extending along the allograft to the anterior horn and mid-body junction, and 3 devices on the lower surface in a horizontal mattress fashion. We place these in alternating fashion with the upper sutures, which are placed in vertical mattress fashion. We are careful to tension the graft appropriately before cutting, being cautious to avoid over-tensioning the graft, stressing the fixation. This technique results in a graft that is well tensioned and appropriately contoured within the medial compartment, as shown here. The anterior root suture is then passed down the anterior root tunnel with proper tension for a secure fit. Final fixation is deferred until the remainder of the procedure is completed. A 3-inch arthrotomy incision is made over the medial femoral condyle, encompassing the previously made portals. The knee is now flexed to 120 degrees to visualize the cartilaginous lesion. A central guide pin is placed and a 20 mm sizer is chosen as appropriate in this case, as it adequately covers the lesion, covering it completely posteriorly, laterally, and medially, with only a small amount of grade 2 change remaining in the anterior non-weight bearing zone. This is reamed to a depth of 15 mm. At the back table, a fresh osteochondral allograft is prepared with the corresponding 20 mm plug taken and prepared using a sagittal saw. Subsequently, the press fit plug measuring 20.5 mm is inserted using digital pressure, followed by light protected use of a mallet for excellent press fit fixation, and the knee is ranged to ensure the graft is adequately positioned. The tibial fixation of the ACL graft is performed using 11 by 25 mm interference screw with the knee in near full extension and axial tension applied on the draw sutures. The graft is confirmed to be stable. The meniscal root sutures are tied over a cortical button at 60 degrees of flexion, ensuring adequate positioning and fixation of the meniscus. We obtain post-operative radiographs in all cases.